We are starting our talk right from the basics, and we'll be proceeding as we with the further speakers how we built up a case. So the first foremost thing is doing a sclerotomy or putting an infusion cannula and the two ports creating. This is the step where we most of the times are really in a hurry because we have to do more of a tough procedures like doing a membrane peeling, might have to settle a very old detachment with a severe PVR. But small things, if you skip, you can land up in a problem which really would finally at the end of the procedure would affect your procedure. It's very easy to place a cannula in a firm eye, but placing a cannula in a hypotenuse eye or in a patient who has already, where you have planned a combined procedure where you have done a phaco and then you want to plan a vitreous surgery, and there is a leaking corneal wound, corneal tunnel or a side port. So how do we manage this? Because in these cases, management, if it is a very hypotenuse eye, first is you need a firm eye so that the port is not subretinal or suprachoroidal or in other place. So inject a air or a saline in vitreous with either a 30 gauge or a 26 gauge needle, whatever you are comfortable with. And once you have a firm eye, and always in such cases, always use a fresh trocar or cannulas, because we are in Indian context, we do not use disposable probes and cutters and everything, and so that is a warning. In such difficult cases, look to it that you use a fresh MVR blade or a fresh trocar. Especially in a combined cases, after you have finished the phaco, don't be in a hurry to wash off the Visilon. Visilon definitely helps you in maintaining the anterior chamber depth, prevents prolapse of a uveal tissue or a iris tissue when you are creating a port, and suture the corneal wound in such cases, which you might remove at the end of the procedure. And always use a fresh MVR. As seen, this is a combined, we have finished the phaco and I wanted to do a PDR case over here. I have already put a suture. This my cannula is not that sharp. I am using a reused cannula. This is a 23 gauge port, and you see when I was trying to put, the whole Visilon flows out with a uveal prolapse. Your job becomes easy once your first port is inside, and then following it you can put on the infusion cannula after confirming that it is in the vitreous cavity. In this era of a MIVS where we talk of a white, aesthetically white and beautiful eye, and we compare ourselves with the phaco surgeons, even a small subconjunctival hemorrhage or a conjunctival tear is not acceptable to us. It's more commonly seen in old patients or a patient who has undergone multiple surgeries. Simple way to prevent this particular tears is avoid using tooth forceps and try to manage most of the steps with a simple cotton tip applicator. And hemorrhage, in spite, if you see, you put a port and you see it's a subconjunctival hemorrhage is happening, just press it with a Johnson bud and it would stop the hemorrhage. A conjunctival tear at the end of the procedure can be managed by just hydrating it with a ringer lactate with a 30 gauge needle, and if it sufficiently slides over your port, that's the end of it. But if it is not covering the sclerotomy, you might have to put a suture, and don't hesitate, always do cover the sclerotomy ports. Malpositioning of a cannula in the form of a suprachoroidal infusion or a subretinal infusion, Dr. Guha has very well covered up. More commonly, as we are aware, happens when we have a retinal detachment with choroidals, a hypotenuse eye, and we are again trying with the blunt instruments. How do we recognize? Immediately you see a flattening of AC, the mounts, choroidal mounts from the periphery and the retina getting pushed into the center of your vitreous cavity. Simple thing is, the moment you feel there is something abnormal, stop the infusion cannula. Check it with an endoilluminator whether your infusion port is inside. If you have a suspicion, if it is not in the vitreous cavity, change your plan of action. Remove that port from there, go to one of the superior ports, put your infusion cannula there. Check it now again. If it is in the thing, you put it on, restore the vitreous volume, and then try to do the suprachoroidal fluid which has already entered. And most of the times it flows out through the port, and then go for a fresh sclerotomy or a fresh site. Subretinal infusion, again, how do you recognize? Suddenly there is a ballooning of retinal detachment, and the retina starts to flow into your vitreous cutter. Again, same port, same thing, close infusion, move your infusion port to a new sclerotomy site, and replace it, and go back to your surgery. Lens touch in a MIVS era, this complication has relatively on rise even at the professional, even at the veteran's hand. Why? Basically because nowadays, as the Dr. Goya said, that our wound construction is tangential, and that is why your port is quite closer to the lens, and that is why we see more commonly with a MIVS lens touch compared to the previous time when we used to do whatever we call a open type of a vitreous surgery. And here again, if you have a lens touch and if the visibility permits, continue with your surgery. But if the lens touch is really bad and it is not allowing you to do a sufficiently good job with your final procedure of a vitreous surgery or memory pinning, don't hesitate, complete by doing a lensectomy or a phaco, and then later on put a lens after as a secondary procedure. Dialysis and tear, why it happens, already Dr. Goa has elaborated on it. Management is simple retinopexy and tamponade. Dislocation of cannula, more so common with a 25 gauge type of vitreous compared to 23 or 20 gauge. Suddenly there is a hypotonia and collapse, and the tips are, again, you should always step the infusion cannula. Second, be vigilant, have a good assistant who can bring to your notice. But in spite of that, once in a while this happens, so it is simple, reinsert the cannula. Sometimes the cannula comes out with the means the port comes out with the complete sleeve of it, and in that case, and if you find that the sclera has become very patulous, you can move on to a new site. Vitreous or retinal incarcerations happen because you remove the instruments at a high pressure. Avoid removing it at a high pressure. Sometimes if the retina is very bullous, you might have to stabilize or push back the retina by using a PFCL or an AR as a tamponade. This is a patient, you see, this is a endophthalmitis. This patient, we had undergone 23G vitrectomy at our place. We had done vitreous surgery, and I was wondering why he should have a predominantly anterior type of a endophthalmitis. When we did a PK with a vitreous surgery for this patient to relieve him of this complication, we realized that the organisms had followed the track of my infusion cannula. So the warning is that whenever you suspect that there is a leak, please do not, otherwise we can land up with as devastating a complication. Hypotonia is easy to manage, but sometimes an infection of this level can be unpardoning. And so prevention is best. Create a good angle shaped incision, spend some more time with it, and whenever in doubt, whenever you see leakage, suture it, just you can put a transconjunctival suture. So if you look at the whole things, whatever port related complication, if we adhere to our basics, that is, how do we create a port, how we have been taught, it is simple. Just push aside the conjunctiva a bit with a Johnson bud, flatten the sclera over that part, use a new trocar, once your cannula goes in, definitely check, find some time to check whether your infusion cannula is in the vitreous cavity, and at the end of the procedure, do an indirect ophthalmoscopy not to miss out a break, and in any doubt, do not hesitate to put a transconjunctival suture. Almost all these complications elicited here can be prevented. Thank you.